Art Institute. We are welcoming you for all the monthly webcast series. This month we are showing two interesting cases of TAVR. One is with a very tortuous and calcific iliac arteries and one with a normal iliac arteries. Our presenters are Dr. Pranay Jayaprakash Gore and Dr. Kavya Annapareddy, and I will hand over them for the next session. We will have a brief introduction and we'll have the discussion while they are addressing the case.
So very good afternoon to all. So today we have come up with two challenging TAVR cases which we did recently. So we thought of sharing that and building the knowledge of each and every one. So it's basically a case of an 83-year-old male who is a hypertensive diabetic and who's undergone a bypass surgery in 2004. He comes to us with dyspnea on exertion for past 20 days. Doesn't match a criteria of severe aortic stenosis, but when we calculated the valve area was 0.8, so it shows that it's a low flow, low gradient aortic stenosis. So we subjected the patient to dobutamine stress echo, and after giving dobutamine to the patient, the gradient increased from 31 to 43 millimeters of mercury. So it confirmed the diagnosis of severe aortic stenosis with a low flow, low gradient. So now the patient is post CABG, 83-year-old with LV dysfunction and severe aortic stenosis. So the best option for the patient is going for a transcatheter aortic valve replacement. So we did a CT TAVR protocol, and this is the CT analysis which is done in 75% of the phase. So there are some important parameters in this slide here. So if we see at the left hand side upper border, we can see the perimeter is 70 millimeters and the area derived here is 365.5 millimeters square, and the area derived diameter is 21.6. So the importance of here is to, when we are selecting a self-expanding valve, we look more into a perimeter and derived perimeter. And when we are looking into a self-expanding valve, we look into the areas and area derived diameter. So here we've got an area derived of around 21.6, and if we see the coronary heights, it doesn't matter too much here because the patient is already post CABG and the grafts are well patent. But if we consider that the patient has got SVGs here, we would like to go with more of a more with a balloon expandable valve. So the LVOT here is more or less similar to the aortic annulus, which is 21.5. And based on the area derived of 21.6, we think that we should go ahead with the valve size of 21.5. If and then upsize the valve later based on the how's the gradients and how's the patient behaving that time. Now directly not going to a 23 valve here, because the LVOT diameter is 21.5, it is similar to the annulus. And sinuses, we can see it is roomy, and the ascending aorta there is some dilation which is 34.5, and STJ is also around 30 millimeters. So this is the annulus phase where they have seen the annulus in a 45% phase, and this is the accurate measurement of the aortic annulus, and which comes out to be 21.5 millimeters. And hence we tried to analyze that, and then we think that we should go ahead with the valve which is 21.5. So now these are the dimensions where we can see that the calcified coronaries and the height of the coronaries, and this tells us the how the patient is going to behave. And if we see, there is no LVOT calcification here, no annular calcification, so the chance of patient having pacing post valve deployment is less. And this is the deployment angles for the patient, and here we can see the aorta is little bit horizontal, making an angle of around 60 degrees here. So that is what is important for us, because when we are going to take the valve inside, the tracking of the valve becomes an issue when we are taking a self-expandable valve. Whereas in the balloon expandable valve, we've got a flexing mechanism so that the valve tracks easily through this kind of vessels. And when we are putting the stiffer wire inside, the aorta is going to bend more. So that would be an issue. And this is the calcification distribution on the aortic leaflet. This is the hockey puck view, and we can see that's a dense calcification sitting over the valve leaflet. Now coming on to the femorals. Femorals, bifemoral, both are heavily tortuous, and if we see the bifurcation here, the right bifurcation is below the femoral head and the left bifurcation is slightly above, touching near the upper border of the femoral head. Both the iliacs are heavily tortuous and calcified. Dimension wise, if we see the femorals are more or less more than 6 millimeters, so we don't anticipate much of problem there. But if we see the calcification rims in the right femoral, we can see there is a calcification, but more in the iliacs, not at the femorals. In the left side, we can see there are some specks of the femoral calcification in the anterior aspect. So we're going to avoid that because deploying a closure device might not hold well. And the femoral anatomy, understanding the femoral anatomy is more important here because the vascular access plays an important role to have a successful procedure here. So the deploying the procedure, the per-close devices will be more important. So we thought we would go with a ultrasound guided puncture for the left side, and for right we will do a fluoro guided puncture. So based on the analysis of the CT, we thought that a balloon expandable valve will suit well to the patient as compared to the self-expanding valve. And selecting a size of 21.5 is more important in this patient because we can later on go up, and Merrill has got intermediate size for this patient, so 21.5 stands in an intermediate thing. Later on, if we see a paravalvular leak or there is a gradient over there, we can just add on some 1 cc or 2 cc into the same balloon and go up again to achieve a good expansion. So we'll stop here and take the opinion from the seniors here to what would be their approach in managing such kind of patients.
Yeah, Rajaram, you can discuss. Yeah, that was nicely dealt. Already, I think you have explained the entire anatomy of the TAVI, because main in the TAVI, the CT evaluation of the anatomy is more important. In fact, your entire planning should be before the procedure itself. So your 70 to 80% of the work is in anatomical evaluation of the access route and the entire route, the tracking of the valve, and followed by the angles, and then site at the valve deployment site. What are the calcification sites of, particularly the sites of calcification? Suppose how is this membranous septum and all those things. Suppose if there is any severe calcification at the leaflets or at the membranous septum and all those things, there is all the more possibility of this complete heart block. And sometimes if it is opposite to that, then it may cause some ruptures or paravalvular leaks. All these complications may take place. So I think the importance of the access of this extreme tortuosity, and then calcification of the wall, this common femoral anterior portion, anterior wall, and all those things. The importance of image guided or ultrasound guided puncture of the femoral artery is also equally important. And the importance of when should we take the basic information regarding when should we go for the balloon expandable valve, when should we go for the self-expandable valves is already you have told nicely. I think required information before the starting of the procedure is adequate. I think I'll pass on this introduction.
See, in case of a tower, the most important aspect is not it is the CT analysis and choosing the right valve. That will take care of the 90% of the care. Rest of the procedure is only 10%. Here, the most important thing, I will start from beginning. The common femoral artery, which is a site of puncture, should be at least 5 millimeters, because we are using a 14 French sheath, python sheath for this thing, Merrill, the size of the artery, common femoral artery, should be at least 5 millimeters. That is the first and foremost thing. Second thing is the iliac arteries, the calcification and tortuosity. If there is any calcification, either we have to do some this modification by doing peripheral IV and all those things. And one more thing, we should know some definitions. We are using frequently what is the small annulus, big annulus, like that. The definition of small annulus is, if it is annulus is less than 430 square millimeters, it is called small aortic annulus. That is the number 1 point. 2 is the measurement should be very accurate at the level of annulus, sinotubular junction, this height of the coronary arteries, right and left, at least they should be at least 10 millimeters. But here it is a post-EBG cases, so the access problem is not much. And the calcification in the arch and the iliac, all those things, they matter a lot in this patient. So before that, I will tell one thing about the assessment. Here it is a low flow, low gradient, the severe AS. There is one more thing called paradoxical low flow, low. The patient has got normal LV function, but the gradients are not various, but the valve area is less than. It is seen in patients of aortic stenosis type D, which is associated with hypertension. Here the LV function is absolutely normal, but you don't get much gradient, but you get the area, it is less than 1. That is number 1. Then choosing the valve, balloon expandable valve and self-expandable valve also is very important. And third thing is deployment techniques, very important. How to place the markers, very important. How much this thing, rapid ventricular pacing should be done, all those things, they are all very important. Here the one more thing is how to cross the aortic valve. That is also very important. Here the either use JR catheter or AL catheter, we should do anti-clockwise with a this thermostatic wire, and we should do anti-clockwise. And before that, if you are not able to cross, you do a aortic root angiogram. It will show the entry point of the aortic valve. If you put the catheter there and do some anti-clockwise and advance the wire, it will go easily in.
So we've analyzed the CT properly. The decision based on the CT analysis and patient perspective, we decided that we'll go ahead with a balloon expandable valve, and the valve size would be 21.5. So there are a couple of challenges which we can anticipate in this case. So the first challenge is the femoral access and getting the devices into the femoral artery, then iliacs, and crossing the tortuous aorta also. The second important aspect which we should not forget here is the LV dysfunction, because the LV reserve is poor, but the DAC showed that there is improvement in the LV function, so there is a good contractile reserve and the patient might have improvement. But the problem here comes is when we are rapidly pacing in such poorly LV, we might encounter that there will be some cardiac standstill, and the patient is graft dependent. There is a graft dependent circulation, so whenever we are pacing at this high rate, there might be some drop in the LV function, and the patient might have a cardiac arrest during the procedure. So there are two aspects which we should do, and that is one more reason why we have selected that this patient should undergo a balloon expandable valve, because we'll be just pacing for a shorter period and then deploy the valve and come out. So we'll see what difficulties we encountered during the procedure. So this is the femoral puncture which we did. So firstly we did a left puncture with ultrasound, and then we took a contralateral injection. So after taking a contralateral injection, we had a ghost image. So the right shows us that there is a ghost image, and we took a puncture needle, and exactly at the midpoint of the femoral head, we punctured there, and we passed the wire with the use of micropuncture needle. So that is how we secured the femoral artery in a proper position, and then that was an adequate and clear puncture. So the left puncture for the venous system we tried first, but the femoral vein was very tortuous, so we changed our gear here. We took an angio, and while taking an angio, we punctured the femoral vein also. And when we were trying to get the wire in, so see, we can see that the femoral venous system is also tortuous as the artery was. So we can see how tortuous the femoral vein is, and that will give a challenge to get a temporary pacemaker inside the patient. So that is what has happened. So we tried to park the temporary pacemaker, but the pacemaker is not tracking because of that tortuosity. And whenever we were trying to put pressure on the temporary pacemaker, the temporary wire used to get kinked. So we changed our strategy here. So we took a stiffer wire with a JR catheter and placed there, and then exchange it with the long sheath. So that long sheath has given a stability here. So when we parked the long sheath down there, and then took a temporary lead, which made things much more easier, and then deployed a TPI inside. So that is how it is done when we are encountering a tortuous venous system. We don't directly push it. We take a stiffer, we try to park a stiffer wire above, get adequate strength there, and then place a temporary pacemaker. Then came the accessing the main axis, where we were trying to get the wire, and then again the tortuosity hindering us. So once the wire was up, we were trying to get the catheter up. It was a bit challenge because the wire was not tracking the catheter was not tracking very good. So slowly with pull push movement, we could get the catheter there, but the catheter is not going up because of lack of support and tortuosity and calcification. So we changed our gear here. We took a much more stiffer wire, Amplar super stiff wire, and tried to get it in, and then we could go up easily. So once the catheters, the stiffer wire was in place, we changed it to the 14 French Python sheath. So which came in, and we can see that the Python sheath is also hindering the artery. The dense calcification of the artery we can see towards both sides. So gently we try to get the Python sheath in, and it is tracking well on the Amplar stiff wire, and it was all done in fluoro to avoid the vascular injury. So once the Python was inside, things were much easier. Then the system came that we took a pigtail from the left groin and parked it in the root, and took an aortic angiogram. And here we can see that in the midpoint, in the upper quadrant, there is an opening. There is a white line, which is the actual opening of the aortic valve. And taking an AL1 to cross the valve, initially we tried with Teflon. We thought that it's a calcified valve, Teflon would go, but the Teflon was trying to straighten the AL1, and the Teflon is not entering. So we changed it again to a thermo straight tip wire, and we got in. So thermo went in, and then we exchanged that it with a pigtail catheter, and a safari wire came in, which is a stiff wire to get the device in. So we parked the safari wire at the apex and got the pigtail out. So here we recorded the gradients. So gradients were around 35 millimeters of mercury. So we were not surprised that we are seeing a low gradients here. The decision of the aortic stenosis, treating the aortic stenosis doesn't change after this, because the patient was given some sedation. We might encounter there is the gradients might come down, and as it's a low flow situation, the gradients might be down. So once the things are inside, we pre-dilated the valve to create some space. So getting 40 the 18 into 14 balloon, and dilating it under pacing, so we have a place to adequately get the device in. So after dilating, this is the valve which is coming in. So it has flexed nicely. We positioned the valve, and we are ready to deploy the valve after checking the position. So here we can see that the pigtail injection, the pigtail is slightly above the annulus. So we tried to position the pigtail a little deeper, and then again after checking the base of pigtail and the center marker of the valve at one place, with under rapid pacing we tried to deploy the valve. So the valve deploying is here at 180 pacing slowly. Initially we see that the valve is opening slowly, and then as the valve started to open, we tried to slightly push the valve to achieve its shape, and then rapid pacing down. The second thing is double tapping, where we push the balloon little bit down, again pacing up, and then dilated the valve, and again pulled the balloon little bit, and again went up with rapid pacing. So what has happened here is, when we went with the second pacing up, there was some drop in blood pressure, and we can see that LV contractility has gone down. So here what we did is, even after giving adrenaline injection, the patient did not recover. So some cardiac massage was done, and as we started doing the massage, we started to see that the ejection is improving, and then short cycle of CPR, the patient came back again. The heart regained its contraction, and the ejection was improved, BP improved, and then that is the nicely sitting valve there. The no major leak, paravalvular leak. The central air we can see because of the catheter, and then this is the end of the procedure. The valve is sitting nicely. Patient is stabilized, and that is how we complete the procedure. And then this is the vascular closure, which was done using 2 proglides. And after having the vascular closure, we always take a contralateral injection to see whether there is any leak or damage to the vessel. The vessel is flowing very nicely. There is no damage. So this is how the procedure is done. And we will go ahead to the next case, and we'll have some brief discussion about the importance of important steps and what are the precautions we will take in such kind of cases, because it's a high risk case. Frail man who's already undergone a cabbage and is 83-year-old.
Actually nice case because advanced age. So this patient initially got admitted in one of the peripheral hospital for acute dyspnea. So then subsequently he came to us, then we evaluated, and because the low flow gradients, again he went back. We planned TAVR and we asked him to come back. But in the periphery, one of the specialists, then he diagnosed it's not very significant, no need of any TAVR. So low flow gradient, definitely interventional cardiologist requires some skill to diagnose, because if you miss it, because it is going to carry a very bad prognosis. Then subsequently, when he came, he approached 3-4 interventional cardiologists. Again, he came to us. Then we told this is a mandatory procedure because LV dysfunction was there. He was suffering from recurrent episodes of pulmonary edema. With the great motivation, we could do this. So here he has shown some of the challenges. You see, even veins are tortuous. So we were forced to use a long sheath. That is very important. Otherwise, if you only push the pacemaker and trying manipulation, one is wasting the time, another one is it may lead to perforations. So again, the approach also very good, because here when do you want to flex the device? That is very important. When you reach the ascending aorta, flex, then go there. Once you reach there, again after placing, unflex. These are all the important. And timing of pacemaker is very, very crucial. So when you switch on the pacemaker, until the pressure drops, that time only you have to implant and see that that pressure is low until you deploy it fully. After that, you can switch on the pacemaker. Otherwise, what happens, it can, one of the most undesirable effect of the balloon expandable embolization. So it can embolize easily. That's the reason you have to maintain low pressures. You see that pressure is not very high. So if these are there, again it can embolize. But I think nicely done, very good device. It's like a implanting the stent only, but exactly annulus keep there and implant. That timing up and inflation time, that is also very, very crucial in managing these cases. I think you can say so.
Here, there are 2 issues. We are doing rapid ventricular pacing during deployment, and while removing balloon also, it should be done under rapid ventricular pacing. I will ask our panelist, Dr. Aparanji, one question, and Dr. Rajaram and others. American Heart Association says TAVR above 65. European Society says TAVR above 70. In India, which guidelines you would like to follow, AHA or ASC? Your valuable opinion, Dr. Aparanji, Rajaram and others.
I think we can follow the same guidelines, sir, because nowadays the TAVR issue is basically the repeat surgeries. That is the only concern. because the life of the valve is around 10 years, the expected life expectancy for average persons even in India is also around 80 or 90. Suppose if you start your TAVR program after 65 years, then initially you can start with the annulus type of valves and followed by, if there is any necessity after 10 years, suppose if you want to repeat it, you can repeat with the another supravalvular type of valves, again you can repeat it. So like that up to uh, 3 surgeries I think you can safely you can deploy, and then we can achieve the target lifespan for these patients. So I think we should also there should not be any hesitancy to adopt up to 60, below 65 years definitely the mechanical valve scores better over the TAVR, but after 65 years I think we should encourage our patients to go for the TAVR valves.
So my question was, when compared to Western population, Indian population is the lifespan is slightly low. So the whether you can do, we cannot wait up to for 60 for patient above 60 also. Can we advise TAVR? That is the issue. I think it is reasonable for Indian patients to advise TAVR for even for patients above 60 years also. We are because we are 1 decade shorter in lifespan.
An average lifespan. Average lifespan may be less in the Indians, but there are nowadays the average lifespan is also going up. So we should aim for the 100 years of the lifespan only. Then I still feel that then no need to reduce the age for the TAVR. I think that is a reasonable guidelines.
We should consider even associated comorbidities.
Yes.
Suppose the patient is having a lung disease, renal disease, even age is not a criteria. If suppose the associated comorbidities, so surgically high risk, sometimes he may be 60-year-old, but 60 years with associated comorbidities, so definitely is fit for TAVR. But in Indian circumstances, even 60 plus, I feel is very reasonable if the patient is having a classical indication. And okay, you assume that right now you are implanting the valve. 10 years later, again valve in valve you can implant. So you can extend another 10 years. But average Indian lifespan relatively less. As Dr. Vijay Kumar said, definitely we are only few people are 85, 90, but majority are average lifespan now 72 years. But I think it's fair enough to give a, especially 60 plus, significant calcific stenosis, LV dysfunction, associated comorbidities are there. But a longevity, physical preserved condition, 60 plus you can give a both options. He can choose based upon his choice. Kavi, you can.
Thank you, sir, for the discussion. Now we will move on to the next case in which we've used a different platform compared to the first case, and why we've done that I'll be explaining. So we had a 71-year-old female who was quite frail. She was asthmatic, hypertensive and diabetic, presented with breathlessness and exertion for the last 6 months. So her 2D echo revealed, actually her ECG did not get displayed, but she had just an LV strain pattern and sinus rhythm. She did not have any bundle branch block. Her 2D echo had concentric LVH, and she had a severe aortic stenosis with a mean gradient of 41 millimeter mercury. Her LV function was normal, and her valve area was around 0.7 mm square. So we had advised TAVI for this patient because she was elderly. She had a high surgical risk patient. So we decided to go for transcatheter aortic valve replacement. And in this first, as was previously discussed, the CT analysis is extremely important. And this is the report which is initially given by the company. Of course, we have to analyze it ourselves as well. So first we focus on the left upper box, which is about the annulus. So her annulus perimeter derived annulus diameter we're getting is 20.1 and the area derived is 19.9. So this comes under the definition of a small annulus, as Dr. Vijay Kumar sir has described. less than 430 square is considered as a small annulus, and if you consider the diameter, it's anything less than 23 So we have an area of 311, and a mean the diameter is 20.1. So both of these come under a small annulus. So in this case, it is better to consider a self-expanding valve. So when we're considering a self-expanding valve, we have to, of course, take the perimeter-derived diameter, because it is difficult for it to conform to the shape. So we take a larger, the larger and oversize it. So if you're considering a 20.1, it's better to take a 26 valve size, because around 15% oversize should be done. But at the same time, it is extremely important to look at the LVOT diameter as well, because if the LVOT is smaller than the annulus, when we're considering a pre-dilatation balloon, we need to downsize it. So as the diameter of the annulus is 18.1, we'll downsize it. So we downsize it by 1. But approximately we've decided to take a pre-dilatation balloon of around 18 And then we should also assess the sinotubular junction sinus of Valsalva diameter. So if you see, the sinus of Valsalva diameter of all three is above 25 which is quite comfortable. Anything below 25, there is a higher risk of coronary obstruction. Anything above 30, we're quite comfortable, but still all of them are above 26, so that is quite okay. The coronary ostia height are all both above 10, and more than 12 is even better, both at 12.9. And the sinotubular junction also is around 20 to 22. So what is important is, if we are considering a 26 evolute valve, the waist is 22 in diameter. So the sinotubular junction, if it was too narrow, it would have been difficult to use that particular valve. So considering these parameters, we can use a self-expanding valve, probably a 26 size. And but what is important here is her peripheral arteries. Her femoral arteries diameters were 6 and 6.1, but on the left it was around 5.6 to 5.7. And the iliacs were also just 6 and 6.2, so relatively small vessels. And what is more important is they were heavily calcified, which I will be describing subsequently. So here we can see that the lepticity index is quite small. So it's almost a circular annulus, around 23.1 into 21. And there's a little bit of calcium over here, which is noticed at the sinotubular junction. It is not too severe. It is around moderately calcified. There's quite some calcium present in the cusps at the valve, but that is good. So it means that it will hold the valve well. And the sinus heights are quite good, and not too much calcification. And the angle in which we got was around 40 degrees, so that's comfortable, not too horizontal. But and now this is very important. This is the iliacs, common iliac, bilateral iliacs, and the femoral arteries. If you can see, especially in the left upper corner, the whole quadrant, you can see it is severely calcified, or a concentric calcification is present. Severely calcified vessels, and they are quite narrow. So because of this, we decided that we will consider using peripheral IVL, so we can have a good preparation and it will be easier for us to pass our valve. Otherwise, we were anticipating quite some difficulty. We thought we would decide based on how we are doing during the procedure. So again, just discussing how we decided the 26 valve. Our annulus diameter was 20.1. So that comes into the... So as our annulus diameter is 20.1, that comes under 26 valve, 20 to 23. The sinus of Valsalva diameter was 26.2, slightly less, but still it is acceptable to use a 26 valve, which needs a 27 sinus of Valsalva diameter. Sinus of Valsalva height we got was 18, and anything above 15 is appropriate for a 26 valve. So, based on this, we decided to go ahead with a 26 evolute FX plus valve. Any comments, or shall I just continue? Yeah, I'll just continue. Okay. So we took an ultrasound guided left femoral access first, and then you can see, then we took ultrasound guided with a fluoro mapping for the right femoral artery. So we used a micropuncture needle, and then we successfully punctured the right femoral artery as well. But after this is where we really, which is what we were anticipating as well. Fluoroscopically also it is quite visible that there is severe calcium in the iliacs and the aorta as well. And our regular wire was not passing at all. It was getting deflected repeatedly. We were unable to pass it beyond this point. So what we ended up doing was taking a PTCA 014 wire, and only then we were able to cross this particular chunk of calcium. So we decided to definitely go ahead with the peripheral IVL balloon. We took a 6 into 60 peripheral IVL balloon and we delivered 300 shocks. So first 150 shocks were delivered in the abdominal aorta, then we pulled it proximally, and then we delivered the remaining 115 in the iliacs. You can see the severe calcium all around. So after that, we just went ahead to do a regular angiogram and her coronaries were normal. Now, after having done the peripheral IVL, our devices and our gadgets very comfortably and very smoothly were able to be passed. So we decided to go ahead and take a longer femoral sheath because we needed extra support. So we took a long, around 45 centimeter femoral sheath from the right femoral artery. Then with the 5 French pigtail from the left side, we went and parked it into the aorta and we took, and after that, we took the AL1 catheter, took a straight tip Termo, and we were comfortably able to cross the valve. It's extremely important to make sure that we do not go towards, and make sure we don't go towards the mitral valve because otherwise we'll cause a lot of mitral regurgitation. And then we exchanged it for a pigtail catheter and we took the gradients. So the gradients we had gotten a 50 millimeter mercury. After that, through the pigtail, we took an extra small safari wire, stiff wire, and parked it into the left ventricle. Then as we had come to our conclusion of using an 18 mm pre-dilatation balloon, we took an 18 into 40 mm Z-med balloon, and with rapid pacing, we deployed it and did an adequate pre-dilatation. After that, we took our valve, which we loaded into the loaded valve was passed with the 14 French inline sheath. And we didn't have any difficulty after this to pass these larger, bulkier gadgets. It went very smoothly thanks to the peripheral IVL. And here we are taking it across into the aorta. And reaching its position. And now once we've reached the aortic valve, so what is very important is the cuspal overlap view is the one which is now used while using self-expandable valves. For balloon expandable valves, coplanar view is more than enough. But here we need to use a cuspal overlap view where the LCC and the RCC are overlapped and the NCC is played open. So here the first 2/3 of the valve deployment should be done in the cuspal overlap view, which has some amount of an RAO caudal. Of course, it should be pre-decided the exact view. And after that is done, the remaining 1/3 is deployed in the LAO view, so that the LCC is slightly splayed open and we need to reduce the parallax. So that's why we do the remaining 1/3 in an LAO view. That is what is being done here. And so finally we did an iotogram after that, and it's showing that the coronaries are being filled adequately. There is no paravalvular leak and there is no central AR either. The valve is sitting very comfortably. And here also the valve's position is confirmed. And this is the final image. We decided to close the right femoral artery with one prostyle and one angioceal. So another reason why we had taken the self-expandable valve is because she had such narrow calcific femoral arteries. It's better to use a self-expandable valve, which we could easily seal comfortably with an angioceal and a prostyle. And this is just another image because we use the Evolute FX platform. These have 3 large windows here, which basically give us good access to the coronaries either during index procedure or for future interventions as well. It is quite useful. It is also very useful in horizontal aortas because it's more flexible. And also the patient prosthetic mismatch chances are also much less, and paravalvular leak cases are also much less after using an Evolute FX valve. So the one which is marked is the larger windows, which helps for the coronary access.
Here the challenge is peripheral artery calcification, the severe peripheral vascular disease. If you see the aorta at the site of bifurcation, severely calcified. If you don't prepare well, what happens? Device delivery is very difficult. Manipulating, advancing is very difficult. Sometimes you may have to use the snare or you may have to use the buddy wire. These are all important to cross the valve. But here, because once you prepare the lesion at a aorta level, that is before bifurcation, See, it made easy. It was tracking very nicely. If you don't have a peripheral access nicely, especially iliac junction, many times they will have a severe calcium. That time device delivery is very, very difficult, tracking difficult. You may have to go through the left brachial approach, put the snare, or contralateral, put the snare, and these are the techniques you have to follow. And IVL is a very useful tool in modifying this peripheral calcium, and so that you can access through the femoral very closely. Another one, narrow annulus. Narrow annulus and severe calcium. If you narrow annulus, severe calcium, if you balloon expandable, sometimes the two things which are common complications of the severe calcium, especially in the presence of bicuspid. One is annular rupture, another paravalvular leak. Sometimes if the calcium may extend to the LVOT, especially non-coronary cusp side, that is toward the bundle of his. So that time also patient pay AV valve. Suppose if it is going to LVOT, the chance of going to complete heart block. So complete heart block, risk of assess the risk of complete heart block, assess the risk of the annular rupture, assess the risk of the paravalvular. These three are important points one should consider. So here, the one of the advantages of this device is generation. Another one is it has three markers, mainly cuspal overlap view. So what you are doing, you are not both right coronary cusp and left coronary cusp, you are overlapping, you are separating the non-coronary cusp, so that when you use in a cuspal overlap view, the pacemaker chances are involving the conduction system is very low. And because two markers, that a left coronary cusp marker, right coronary cusp marker, if you overlap and if you separate the non-coronary marker and overlap the other two markers, so that itself shows that it's a cuspal overlap. This is one of the important. So the basic advantage of this, one is device delivery, another one is coronary access is very good because the cell size is much bigger. So that's the reason you can access the coronary arteries very freely. Moreover, it's a self-expanding. The annular rupture is very less likely. But only thing is, once you implant it, if there is a paravalvular leak is there, take the upsized balloon and you can increase the size so that the paravalvular leak can come down. These are the important issues in implanting this valve. So over to Dr. Vijay Kumar.
I would like to discuss and interact with our panelists about three important parts. So calcific aortic stenosis is a disease of age. If the patient has got significant CAD, when you plan PCI, before TAVI, during TAVI, post TAVI. Rajaram, Prashant, and others.
Shanti, you can discuss before or after. If the CAD is there.
If there is any coronary artery disease, I think it is better to do during the procedure itself, sir. There is no contraindication. If patient is stable, absolutely stable, then you can plan it before also. Because to avoid the extra procedures and all those things, most of the times we do coronaries in the same sitting when the TAVR is planned.
Others' opinion, please.
So it depends also on the anatomy of the coronary artery disease. If they're more of left main diseases, better you do it before the TAVI. Otherwise, access might be difficult. And if they are borderline lesions, then it's better to do after that because functional assessment might be more accurate after doing a TAVI.
So post TAVR with the coronary access is difficult or not. That you see, what is the coronary height? Coronary height is reasonably good if you are able to access very easily. Roomy sinuses are there. Everything you have to decide. If the coronary sinuses are roomy and the coronary height is very more than 12 mm, good height is there. So you are very sure that once you implant the valve, if you are able to access, then that time. But any time before doing TAVR, after TAVR, accessing is very difficult because you have to access through the mesh. So whereas doing, especially with the complex coronary disease there, you always decide whether to do TAVR first or this one. But if the very severe critical aortic stenosis, always they recommend the aortic valve first. And but regarding coronary, suppose if the severely calcified torch vessels are there, I personally feel first you do the, but mentally prepare. If something goes wrong, immediately you should be able to dilate and put the valve. But always try to tackle the coronary arteries. If it is very complex coronary anatomy, very difficult to access, in such cases you can. Suppose right coronary is there, only one vessel is there. Okay, you are very sure, like a big cell is there, you can access very easily, roomy sinuses, height is very good. After that, if you want to, but always you try to protect the coronary artery. Keep the wire inside the coronary artery. If needed, you can keep the guide liner and access the coronary artery. Through the guide liner, maintain the stent. Suppose if once you implant the stent, if suddenly it closes, you should be able to put the stent and implant it. So life-threatening situation. Otherwise, what happens if suddenly if you occlude the coronary artery, that is especially important when the coronary height is very small, or if the calcium, when you crush it, it is extending up to the left coronary. That is a major life-threatening situation. In such case, always keep the coronary artery, if needed, through the guideline, keep the stent inside the coronary artery, and if emergency is there, implant it and come out. But always very complex anatomy. If the aortic stenosis is not too critical, that time go with pre-procedural coronary intervention followed by this one. But if the critical stenosis really patient is having LV dysfunction, very life-threatening aortic stenosis, first to tackle that. So once you tackle, most of the time, hemodynamically he will be stable. After that, you can address the other things. Sir, you can come.
Notion 3 trial says you do this thing if the patient has got a significant CAD, PCA, FFR guided PCA versus medical management shows there is a FFR guided PCA is definitely it shows there is a reduction of MS. There are another two issues I would like the opinion of the forum. Thinking we are in this case we have used peripheral IVL. What how it does it differs from the normal coronary IVL. That is point number one. Point number two, what are the predictors of conduction disturbances in TAVI, in ECG or during technical things during procedure?
Yeah, this guy is right. With everything you can.
Yeah.
Difference between peripheral IVL and coronary IVL, predicts of conduction disturbances pre and during TAVI.
The difference between coronary IVL and then peripheral IVL is usually the aortic wall, the balloon, it is not, it should be less than 0.5 the diameter, sir. Usually we should take the lesser size for the IVL in the aorta, and then regarding this.
So basically the size of the balloon and the pulses which are delivered. So coronary pulses is basically one cycle we deliver is 10 pulses which is given by the coronary balloon, and when we deliver one cycle of peripheral balloon, it is 30 cycles which is shocks it is delivered in one cycle, and that is how we deliver 30 pulses. So we deliver 300 shocks for the patients in different cycles. So that is how it is different than the coronary this thing.
See, we are giving 6 mm, 7 mm and 8 mm. Ultimately, create some, suppose the iota 6 mm is there, 6 to 7 mm, adequately it's modifying. That you can, device will go and flow will be maintained. It's not like a coronary size, under 0.5. Suppose iota size is almost, nearly if you take the descending iota, it's about 2.5. If you come to the below the renal artery, it may be 1.9 to 2 centimeter. So it is not possible to keep the 2 centimeters. Only you can 6 or 7 diameter, you dilate it, plaque modify. After that, that passes enough, it will allow. That will also allow the flow. So that is important. Only the number of pulses are more and the length of the balloon is more. Here the 60 mm, so almost 6 centimeters. So it covers the maximum length, whereas the coronary 12 mm. 12 that is like 120 pulses, and each like 10 pulses we are giving 120 There you have equal size to the coronary artery. IVL always equal size to the, but there is no such for peripheral. Peripheral you can use 6, 7, 5 and modify, but descending aorta, the size is much bigger. That big size is not there. So that yeah. Predictors.
Predictors is one is QRS dilatation, sir. If there is any prior QRS dilatation or right bundle branch block or left bundle branch block, or if there is any PR prolongation, axis is different, then you should be careful and be prepared for the permanent pacemaker also. These are the rough predictors.
And also, sir, presence of calcium near the membranous septum.
That
That
is
also
anatomical
is
factor.
anatomical factor, but that also is one of the clue.
Low implantation.
Yeah,
Low
no
implantation.
implantation.
What is the normal lifespan of a TAVR valve? Is there any newer modification which are lasting for more number of years?
Usually it is 10 to 12 years, sir. Even with the treatment, this calcium resistant chemical treatment they are doing for the valves to reduce the calcification, but still we feel that it is around 10 to 12 years is a comfortable period. Basically, we do not know. It all depends upon the hemodynamics and comorbidities also, diabetes and other comorbid conditions. But basically, average lifespan of the valve is around 10 to 12 years.
Nowadays, there is a
Newer valve with Relicis. So they've got that dry valve.
lasting, that is when compared to routine valve. Usually, the valves that we are using right now, they are 8 to 9 years that is lasting, but newer valves, they are extended life. They are carrying throughout the life.
And that also depends on how the patient profile is, the ongoing inflammation and all these things. So they have shown in when we were in Astana, they have shown that Evolute initial platform, 13 years implantation, Evolute was doing well. So that is one of the experience they have with the Evolute platform too.
Until longevity they have shown in motion trial. The average is showed 8 to 9 years. So now actually many, that's the reason if you see the lifespan, average bioprosthetic, it's like a bioprosthetic, they are saying 10 to 12 years. So you put the bioprosthetic valve 10 to 12 years, another one. So just now somebody mentioned, like if you are putting valve in valve, two self-expanders hazardous because more overlap of mesh. If you are going for valve in valve, the first valve should be balloon expandable. 10 to 12 years it will last. After that you can put a self-expanding valve, extend another 10 to 12 years. Though practically it says, but many times, okay, assume that 60, 65, you put a bioprosthetic valve. And 10 to 12 years later, if the patient is having a problem, that time you can go for self-expanding. Suppose 60 years if you are putting a mechanical valve, I was assume that in 15 years is getting degenerated. You can't put any bioprosthetic TAVR that time. Again, he has to go for a redo surgery, especially in Indian circumstance. I feel even 60 to 65, especially not only simply as associated comorbidities are there, assume that another 10 years later there may be a chance of another one. That time if you go with a bioprosthetic valve, then there is a chance for extending another TAVR. Initially if you are doing surgically also, go for bioprosthetic, then go with another bioprosthetic like a self-extending valve or this one. The combinations are useful. We can conclude, sir.
So the saga of the CME and webcast from this Sunshine Heart Institute is never ending, and every month we'll come with a newer and newer concepts, ideologies, and your exchange our views, thoughts, process, and we like to share your inputs also. And for the bye-bye from time being. Thank you.